So I just want to start out today by welcoming Dr. Peter Scire back again. He has been gracious enough to offer his time up to do this with us monthly. Unfortunately, we had to skip last month because of my travel schedule, but we are back again for the month of June, and we're going to continue our conversation that we've been having about, well, we started going back right from the very beginning of what the basics of functional neurology and why this is so important to look at the function of the brain of our children, to identify opportunities for healing and improving function overall. Today, our topic is what does emotional regulation have to do with the cerebellum, which is something that is new to a lot of people in this space, because we've always thought of the cerebellum as the part of the brain that controls motor function, and that was about it. And we're going to talk a lot more. We talked about working memory the last time in the cerebellum. Today we're going to talk about how it impacts emotion. Before we get started, for those of you that don't know Dr. Peter Scire, I actually just realized I don't have your bio in front of me. We've chatted so often. Well, you know what? One thing I can tell you is Dr. Scire has his son just recently graduated from high school. So how are you feeling about that? Let's talk about that first.
Pretty excited. I actually just got back from the University of Georgia, and we were up there for orientation the last 2 days, and it's fabulous seeing your son get into a prestigious school. They're very proud of their 13th best ranking in the United States in public universities. So it's really awesome. They did a great job there. But it was very fascinating. And actually, I was thinking about this as I was literally in the orientation classes. I was scrolling through papers and thinking about how we're going to frame this conversation. But what really struck me as I was sitting in these orientation classes for parents and then co-mingling with the students, how many of the orientation leaders were talking about their anxiety levels.
Yeah.
And then a lot of the kids, and then I got talking to some faculty members, and then I actually heard the Vice President of Academic Affairs talking about the level of anxiety that these college kids are having. And again, it was interesting to see what their perspective was on it now as I was filtering it through my functional neurology aspect and looking at kids' posture and eye movements as I'm talking to them and stuff like that. I began to really kind of dig a little bit deeper into it, but it's an interesting topic because it's definitely there for the amount of college kids, and really looking at how they're dealing with that, whether they're dealing good on a mental health level or they're on medications. I would have loved to know the percentage of the kids that are actually on meds. It would have been interesting to find out. So,
yeah.
But yeah.
It's big change. And you've got your son working in your office for the summer.
Correct. Yep.
Before we get started, since I have to apologize for being so unprepared, not having your bio in front of me right now, why don't you tell people, we'll start by just talking about what you do at your office at the Scire Center, and what types of patients you see and the type of work you do. You can describe it that way as opposed to all the different degrees and designations we have after your name.
Well, I think first and foremost, I'm a functional neurologist. That is what I've been doing for a better part since 2001, when I first took my first functional neurology course through the Carrick Institute, and then went on to do a tremendous amount of hours through them, as well as the International Association of Functional Neurology and Rehabilitation. I've spent probably 500, 600 hours working collaborating with Dr. Malo, have taught some of his courses as well. But ultimately, I really am truly into neurology. I do have a tremendous amount of background in functional medicine, especially through the Karazian Institute, or all of the Tis Karazian's work through Apex Energetics. I've taken his courses, probably again, upwards of 1,000 hours through the combination of his education and Dr. Brandon Brock and others. So I really think I practice integrative functional neurology, where I can merge both worlds. But at the end of the day, if I had my everything I do, I'd be doing functional neurology in and out. But you do have to account for the metabolics. That being said, sorry, I don't know what just happened here.
I've got you still.
Okay, you got me?
I do.
That is weird because I don't see you. Um, but anyway, let me see, hold on. There we go, I'm back. Okay,
Okay.
well, in my office, I see a variety of patients. I see any patients from traumatic brain injuries to concussions to athletes looking to increase their athletic performance. Um, I have neurodegeneration patients. I have a variety of different neurological disorders like MS. I've had patients that have had motor vehicle accidents that then develop pain syndromes or have had a TBI and that. A lot of my work recently over the last several years has been working with the younger adult population. I think part of it has been I went from working with the younger population um, through my brain balance centers and from 2007 to 2015, which was a great experience working with that population. But one of the things that kind of happened simultaneously in my life was my children started aging, and as my own son got older, I started seeing the need to, and I would to work with more of that 17 and 18-year-old population of kids that we weren't working with in the centers. The centers have always been primarily between probably 4 and 15. I do some peds. I have families that are other practitioners that will send me a pediatric case of a child that's probably between 1 to 3. I just recently evaluated a 16-month-old that was being thought of maybe being on the spectrum. So I get a variety of cases, but right now I think my wheelhouse is definitely the young adult population and then probably that neurodegeneration population. And people ask me why those two, because they kind of seem opposing, but they're actually not.
Hmm.
Because in a lot of ways, the symptomatologies that you're seeing or the functional capacity of their nervous system, one, you're seeing degeneration. So you're actually seeing the brain backslide in its functionality. And then in the younger adult population, you're actually seeing not the brain not mature to that natural maturation to 24 and 25 years old as the frontal lobe should fully develop. And so it's fun because I've learned how to better treat that younger population by working with the neurodegeneration patients, and then also learn how to work with the neurodegeneration patients in a better way by working with the young adolescents or young adults and stuff. So
Yeah. Well, and it like I said, it is interesting because we're seeing that great big chunk of the population with the neurodegeneration, but it is the same thing. It's just in reverse. It's
yeah, and then again we're both parents and we're both in that situation where we have adolescents, teenagers, and stuff like that, and young adults. And so we're in that age group now where most of us are probably likely to probably have an adult, a parent, or
Mhm.
maybe some of us still have grandparents that are alive that are on that tail end of the 80s, 90s that were probably in that neurodegenerative dementia, Parkinson's, Alzheimer model. Um, and now we're all looking at our parents and seeing that discussion. And so, because that's, I know one thing that I've worked with my own mother on at 64, 65 now, and really spent the last 4 or 5 years getting her brain better metabolically as well as on a neurology level to make sure that she's aging very well and stuff like that. But then also seeing a lot of the families that I've worked with over the years call me up and say, hey, what can you do for my parent? You did stuff work for my child. What can you do for that? So it's definitely in those population of people that are probably 35 to 50, they probably have that seesaw on both ends now. So
Yeah. Yeah, no, it makes a big difference. So we wanted to talk about this. Actually, I'm really excited about talking about this because we were trying to decide what was going to be the topic for this month, and I think we both simultaneously talked about emotion and the cerebellum because there is this misconception out there, or maybe it's just lack of the evolution of the knowledge getting out to the mainstream, that the cerebellum is more than just has more of a role than just in the motor coordination that we always were told, or at least I know as a parent of a young child, it was all about the motor coordination in terms of what we were doing in the rehab that way. So I'm going to let you take over today and tell me how is it that you have come to see, and I guess through the research as well, that we now need to look at the cerebellum as part of our rehab strategy for the kids'
sure.
emotional regulation piece, which is such a huge piece.
Sure. Well, I think, for me, I think that journey started when I was in grad school. I mean, I started chiropractic school in 98, and by 99 and 2000, I was very fortunate to meet some particular postgraduate professors that were really talking about the cerebellum. And obviously coming from a chiropractic education, we were talking about it in terms of spinal manipulation and what is the central effect that chiropractic adjustment or spinal manipulation has on the central nervous system. And we began to understand more of it through the loops of the cerebellum. But around that time, I really ran into this practitioner named Dan Murphy. He's actually a Life West professor. He's been teaching now for, 30 some odd plus years. He's been practicing for 40 years. And he was actually the person that introduced me to functional neurology. I actually took a course through chiropractic biophysics where he was teaching, and he had this particular lecture. It was one of my best friends who has been my son's godfather all these years. We decided to go off campus and see this lecture, and it was called Posture and Systemic Health. And he just blew me away when he began to start talking about the role that posture and the role that the cerebellum has in all these different physiological functions. And again, this is 1998. So then I got to see him again about a year later, and he starts talking about this particular researcher, Jeremy Schmamann, and he'd just written a book called The Cerebellum and Cognition. And so I was like, wow, this is and he just put a couple pages in the notes and stuff like that, and a couple references from Schmamann's work in PubMed. So I ran the researcher down. At the time, he only had a couple papers, but he'd published this really cool book. So I went and found the book and started reading it. And then around that same time, maybe about towards 2000, 2001, again, I started taking my first functional neurology course. And when you take functional neurology courses, each weekend is a separate topic. And next thing you know, you get to this whole weekend of 15 hours of just talking about the cerebellum and all the intricate circuits of the cerebellum. And then again, that reinforced it more. And then I meet Dr. Malillo in 2001 and start taking all his courses. And then he starts layering in all the work at that point and understanding the role of cerebellum in childhood development disorders. And so now fast forward 15 plus years, and now we not have just Schmamann looking at this, but you have other people like his research lab, students that have gone on to other universities like CJ Studley and others. And so now there is no doubt that there is a definitive change in what is the role of the cerebellum neurophysiologically in the human brain. It's no longer just thought to be part of this one system that controls posture, equilibrium, controls your gait, controls your balance, has relationships with eye movements. That is just one subset of what the cerebellum does. Now, what's so important and why is it such an important topic for our parents and others is that obviously we know in the developmental arena that you can look at whether a child has ADHD or autism or learning disability or some other XYZ diagnosis that we want. And we can probably go right into that particular stereotypical relationship of the cerebellum and find all kinds of things symptomatically. We're going to find balance problems. We're going to find muscle tone balances problems. We're going to see ocular motor issues. We're going to see problems in their vestibular system. And again, that's what the occupational therapy space has been really good at doing. Sensory motor body movers, chiropractors, and others. But again, if you're only in that space, you've now are pretty much probably 20 years behind in what the literature is saying, because the literature, again, Schmamann published his book in 98. Now you look up Schmamann in PubMed and he's probably got 200 papers to his name. Okay. So over the last 20 some odd years, the amount of information just from one researcher, no less all these other researchers that are saying that, listen, guess what? When we were talking about posture and equilibrium and motor tone and eye movements, we were only talking about the anterior lobe of the cerebellum that is tied to the sensory motor parts of the brain. We were not talking about the posterior cerebellum. We were not talking about the vermis in the cerebellum. And again, and how we weren't talking about them because we didn't have the technology yet. We didn't have the ability to image the brain the way we do now. Now we can do all this remarkable functional connectivity research and look at the brain in an active mode, and we can look at it in a silent mode, in a rest mode. And so we can look at resting functional connectivity studies. We can look at active connectivity studies. And now it's a game changer. And so in 98, Schmaman comes out and he publishes the CCAS model of cerebellum cognitive affective syndrome, and begins to start looking at all these patients that had damage to their cerebellum, and the type of symptomatology they had. And it wasn't just posture, balance, gait. They had problems in their affect. They had problems in their emotion. They had executive functions. So again, now you begin to sit there and go, okay, if that happens in damaged cerebellums, what happens if the cerebellum is not fully forming and doesn't have the structural and functional organization that is expected? Now, again, fast forwarding 20 plus years, we have all this literature on all these developmental disorders that show, guess what? We have architectural problems in the cerebellum on a structural level, meaning at the micro level of the actual cellular aspects of the cerebellum, but then on the functional aspects, meaning now the pathways from different regions of the cerebellum to the brainstem or to the cortex.
Yeah. So what do you typically see? I mean, we started to have this conversation before we got on, in terms of, obviously you were able to do these functional tests in office that show that the cerebellum is not functioning well in terms of the motor, the gait, all those things. So what does that look like? So when you're looking for this and you can see those things, first of all, what are you seeing? And then obviously what you're alluding to is that we can obviously rehab those things, and what types of outcomes have you seen by doing that type of work?
Sure. Well, it first starts out by looking at the symptomatology first. So to me, I think it's more about, if we're looking at these different various disorders and again, and applying them even to the adult population, again, if we're seeing problems in emotional regulation, okay, we're seeing alterations in social cognition, okay, we are seeing problems with inhibition, okay, whether on an obsessive level or compulsive level, okay, difficulty with the perception of pain, okay, in terms of perceiving pain in my own body, or being able to recognize pain, or being able to recognize nonverbal relationships on another human being, okay? So, and we know that's spread across the continuum of these neurodevelopmental disorders, and the same thing with various neuropsychiatric disorders. So that being said, is that if we're seeing that presentation of symptomatology, now we need to go and look at the sensory motor strip of the cerebellum, and now we correlate that and say, wow, if we have postural muscle tone problems, we have gait disturbances, we have alterations in eye movements and stuff like that, and we have executive function issues, working memory issues, all those wonderful cognitive skills, then we know that one of the main primary problems is the cerebellum. And so if we just try to go up there and we just try to treat into the symptomatology of emotional regulation through, again, different behavioral therapies or cognitive-based therapies, and the same thing with social engagement and the various different social kind of skills assessment therapies that are out there, I think we're missing the boat, because at the end of the day, the circuitry is coming back through the cerebellum. We're actually finding out that we can actually perceive pain through the cerebellum. The recognition of empathy happens in the posterior vermis aspect of that, okay, to be able to really recognize and infer what somebody else is thinking. All the work of theory of mind, Tom, all that aspect that was done by Uta Furt and her teams and others in relationship of being able to, again, put ourselves in someone else's shoes, be able to recognize what someone might be, their states of feelings based on their nonverbal cues. You cannot have that unless the cerebellum is particularly working. And specifically this posterior vermis area that's tied to an area called your vestigial nuclei, which is one of your deep nuclei in your brain. You have 4 deep nuclei. And again, this is all being linked into these limbic circuits. So there is literature about a lot of basically structural and functional issues in that posterior vermis in children with autism or ADHD, and we're seeing it in the adult population. So again, if we're not getting in there and actually looking at those clear motor cerebellum issues and not addressing them, I don't believe personally that you can address these non-motor functions.
Yeah. So first of all, one of the reasons why I love talking about this is, and I'm going to talk from personal experience working with you and my daughter, we saw such a massive change. And that was one of the things that was so surprising to us when we started to do the work, in particular that focused on the cerebellum. The impact on cognition and emotion was a surprise to us. And because we had done so much work in those areas with other things, like you said, you're doing a top-down approach as opposed to getting to the root of things. And all of a sudden we saw this huge acceleration. Is that something that you typically see with your clients when they come and start doing this type of work?
Yeah, and again, and because more than ever, I have a variety of different neurological presentations now. And especially when you start looking like, again, for someone who spent the better part of his first decade of his career working with children with developmental disorders, and really that was 99% of what I saw at that moment was kids, and again, from 3 to 15 or so. But then over the last 4 years now, to have a more variety of patient population and adults that come in with a variety of different health issues, and they may be coming to me perfectly for a metabolic issue, but when I actually assess them and realize, no, it's actually, that's a secondary finding to a neurological aspect, and then you start doing an assessment on them, a functional neurology assessment, and you start seeing their cerebellum have all types of issues. But the really cool, interesting group of people is the TBI patients and the concussion patients, and what happens to them in their cognitive functions and their emotions and especially their emotional regulation. They become very, they lose inhibition. Their part of their brain, their midbrain becomes super active. One, because they lose inhibition from their frontal lobe because of the mechanism of the injury. In most instances, in a traumatic brain injury concussion, is going to have a lot to do with the frontal lobe. And then also the idea that now they become super sound sensitive and light sensitive because that midbrain is actually has two major big groups that receive auditory input and sensory input. So as I started working with the TBI population of patients, it really gave me a different perspective because again, when you start working in the autism world, a lot of times you're working with cases of kids that they can't express obviously what they feel and how that light, they're stimming on that light, or that light, they're light sensitive or sound sensitive and stuff like that, but you don't know how it feels. They're not expressing that. But a TBI patient, for the most part, can tell you what they're experiencing when they stare at a computer too long, or they're going down the road and their optokinetic system, their rapid eye movement system is not fast enough to process the movement and what it's doing that in terms of perception of equilibrium and dizziness. Game changer clinically for me to be able to sit there and extrapolate that back to now what I saw clinically on children, and give me a better way to explain to parents of, hey, this is what actually is probably really happening in your child and what they're experiencing at that moment. But what I can tell you without a shadow of doubt is by doing cerebellum rehab and focusing that rehab, because again, with the cerebellum, everybody has to remember that the vestibular system is integrating through that. Your proprioceptive system is integrating through that, okay? It's a big hotbed for these major loops. And when you're working with TBI or autism or ADHD or depression, you have to facilitate that integration. And once you do that, then you're going to see their working memory improve. You're going to see their cognitive endurance improve. You're going to see them be able to remember, how to spell or write, because you've had patients that, in a TBI, all of a sudden it's like, man, I can't write anymore. My handwriting's changed and stuff like that. So again, these are the things that as you start improving the integration of the cerebellum, and what the cool thing about it is that from a therapeutic standpoint, to rehab the cerebellum, it's doesn't have to be over sophisticated. It can be. I have hundreds of thousands of dollars of equipment in my office that makes things pretty interesting to do. But the reality of it is, even if I didn't have that, and you know that, we've done some pretty cool things with your children and not have to use anything really sophisticated to do that, we can still impact that cerebellum and stuff. So
yeah, I think that is one of the things that is so exciting about it for me and for sharing it with other parents, is because so much of what we do is very expensive, and it's a little overwhelming. And I always tell parents that when you're first going to go and do some functional neurology, I said, don't be surprised by what may seem, to us initially a very unusual thing to be doing, or and you need to ask those questions why, so that you do understand, because you have to understand the impact of what to the layperson is sort of interesting exercises, but not understanding what the impact is of doing that, and the repetitiveness of them for their child in terms of the impact that you're going to get. But it's a very accessible type of treatment. And that's why I think it's so great that you can do it, and you don't need to do any types of invasive imaging or testing in order to determine whether or not this can be helpful as well.
no, not at all. You can do a very good, any competent functional neurology should be able to do a very comprehensive bedside cerebellum assessment. And again, anybody who's probably coming from the occupational therapy world, physical therapy world, chiropractic world should be able to, even in the medical neurologists, again, should be able to do a basic cerebellum assessment. Now, how it's interpreted is going to be a little bit different. Medical neurology is probably going to interpret it in a very black and white relationship, where functional neurology, we're going to live in that gray zone and look at the subtleties of the assessment of that we're doing, whether it's a finger to nose test or a dysdiakinetic movement of a hand, how we may quantify that versus a medical neurologist or someone else who's got some maybe training in that might be a little bit different. Those subtleties to us, we do believe they matter. And again, for someone who's been doing this a long time, it does matter. And then again, when I first got into the work, it was very low tech. Now it can be very high tech if you want to have that kind of clinic. If you want to have all the gizmos and you want to be able to have some things that are very measurable and very concrete for the mostly I think for the parents or for even the patients. My patients, when they come in and they're utilizing some of our touchscreen technology for vestibular rehab and eye movement therapy and stuff like that, there's a great benefit of them being able to see their scores and being able to see how inefficient their neurology was at first, and then 12 treatment later, they can look back and they can graph it and stuff like that. So that is the one benefit of having some of the high tech stuff, that you can see it. And then when I'm interacting with other members of the medical community, I do get a fair amount of medical neurologists now referring to me, because they now know we have this state-of-the-art technology to do it. But at the end of the day, I wouldn't need that. If I just had a child or an adult in front of me, I still could be able to examine their cerebellum, find out what's going on inside that cerebellum, and then be able to come up with some really very accessible targeted treatments that can be done and can be reproducible and trained to a parent or a caregiver to do it. It doesn't have to be overwhelming. So.
Yeah, actually, and to that, on that note, actually, we had a question come in ahead of our conversation today when I asked for questions. And a gentleman by the name of Alan asked, what are some of the exercises or activities we can do to strengthen or normalize the cerebellum? So
sure.
If you can give some examples. I know it's different for different people depending on what you're doing, but.
Well, we have to isolate out, obviously which cerebellum is weaker. Okay, you have two cerebellums, and so number one, you have to begin to look at the cerebellum and say, okay, which one is more of giving us problems. And one of the easiest ways to do that is actually just do some muscle testing, and we can muscle test proximal muscles. We can muscle test muscles of the shoulder and the hips to really see whether or not that's a weaker presentation from one side to the next. There's actually specific eye movements that correspond to one cerebellum than the other. So the directionality of an eye movement can indicate which cerebellum might be failing or under functioning. Doing a one-leg stance, actually having someone stand on one leg and balance on one leg is also a very way to do it. Directionality of a fall in terms of a sway pattern, when we have somebody put their feet together and just stand in what we call a closed foot Romberg's test, and looking at the sway pattern, okay, can be indicative. General rules, you're going to sway. I mean, again, it's a very generality that you're going to sway into the weaker cerebellum. Okay, so those are some things that we need to do in terms of looking at some basic stuff. We can look at different movements like dystiokinetic movements like this, or finger to nose testing like that, and isolate out and say, okay, if I see this breakdown in my right hand, or I see a breakdown in the accuracy of the movement, which again is what we call dysmetria, when we look at the lack of fine control. Dystiokinetic is actually this smoothness. We want smoothness and rapid alternating movements and stuff like that. Again, we can, when we look at gait, we're looking at ataxias. Where ataxia gets a little bit complicated is that you can actually have an ataxia to the cerebellum because you have a gluten antibody, or an antibody being produced in the cerebellum by gluten and stuff like that. So you can get a little bit deeper there. But those are things that we can do to look at the cerebellum in terms of a functionality. There's things like we do a heel shin test, where we ask a patient to take their one foot and put it on their opposite knee and slide it down their leg and stuff like that. So there's ways to kind of just look at that integrity of the cerebellum. And once we isolate out, then the beauty of the cerebellum, it actually is a very, what we call ipsilateral pathway, meaning that if we want to impact the right cerebellum, well, if I just start moving my right arm in a very complex way, I can impact the cerebellum. Now, that might be too much for somebody, because that might be too much requirement of a movement. So rather than do a multiplanal movement, I might do basically one plane movement, because it's a little bit less of an activity for the cerebellum and stuff like that. I can move the eyes in a certain direction to activate the cerebellum. Again, we can do, in the chiropractic world, we can do chiropractic manipulation on one side to impact the cerebellum and stuff like that. For those that are used to doing, let's say, some type of tactile activity, like brushing or using vibration or something like that, you can use that unilaterally. So usually it's going to unilaterally. Keep in mind that if I'm using it on my right cerebellum, it's going to probably have a bigger impact on my left cortex, because that's how they're hardwired, and vice versa if I do some stuff on the left. So again, we do also want to take into account for some of the hemisphere patterns that we might be seeing from a child as well. But the reality of it is pretty simple in the sense to where there are more complex things to do, but on a simplistic level, if we want to just do some basic things, if we want to do a slow spin, if we want to spin somebody in a slow way, the direction of that slow spin, if it's a counterclockwise slow spin, we're going to impact the left cerebellum. If it's a slow spin clockwise, we're going to impact the right cerebellum. So there's some basic generalities, but at the end of the day, it comes down to we better isolate out which cerebellum is the one that is the weaker one.
Well, actually, let's just talk about that concept for just a minute. For the people that aren't familiar with that the concept of the looking at the hemispheres in terms of what's weaker and what's not, why is it that we want to make sure that we're targeting the right the appropriate side?
Appropriate side, yeah.
I shouldn't say right side, because it could be left side. Correct side of the cerebellum. And what's the impact if you don't identify that appropriately, or what could be the potential impact?
Sure. Well, one, again, we've been looking at this idea of functional connectivity between the two hemispheres, or the synchronizational relationship. And again, it's often referred to as functional disconnection syndrome. I mean, the literature, Dr. Robert Malone has been given a lot of credit over the last 15 years or so of really bringing it to the forefront, but the actual term goes back a long time. It actually goes back to the split brain research by Roger Scire in the 60s and stuff like that, and Norm Gershwin and others. Okay, but Dr. Malillo was the one that really took the literature over the last 10, 15 years and brought more attention to it. And because for a while there, it came out of vogue. It wasn't a big part of the literature research in the late 70s, 80s. And then once we got the neuroimaging in the 90s, we came back to realize that, guess what? There is a hemispheric pattern or hemispheric bias to, if not all these developmental disorders, a majority of them. And so when we look at disorders like autism or ADHD or OCD or Asperger's, we're going to look at more of a greater functionality, a greater expression of their left hemispheric functions and an underfunctionality of their right hemispheric functions. Mm-hmm. The literature is pretty clear on that. For the most part, I would say 90% of the literature really makes that distinction, to sit there and say that, hey, we see overconnectivity, meaning we see greater bandwidth, we see greater functional connectivity, greater strength in the neural networks that exist within the left hemisphere. So we see this intra-hemispheric connectivity be very dominant. And this is what leads to these great skills that we see in these what we'll refer to as splinter skills, these skills that are so augmented functionally. And why can a child or an adult with autism have the verbal function that is equivocal to their age development or way beyond, yet they don't have comprehension skills, or they don't have ability to look at the big picture, or lack visual spatial integration and stuff like that. So again, we're really looking at this as a functional disconnection, that there is an imbalance in the basically processing power, the connectivity power from one hemisphere versus the other. So that being said, if we're saying that in, let's say, the instance of autism or ADHD or obsession compulsion disorders, Asperger's, when we look at this and say this is a genesis of more of a dominancy in their left cortical networks, their left hemispheric networks, well, the right cerebellum is yoked to that. And so what we're also seeing in the literature is that we're seeing enhancement in the right cerebellum. Mm. And the right cerebellum is very tied to all the language centers. So hence, why do we see hyperlexia, an increased relationship of this language skills in autism, and especially more high functioning autism to Asperger's. In moderate autism to severe autism, it's a little bit of a different game, but that relationship there. And so that instance being is that if you were to treat into that stronger cerebellum, you're going to only enhance the functionality of that stronger hemisphere. Mm-hmm. And then what we also know it happens in the brain is that there's inhibitory circuitry that crosses the corpus callosum that is there to have a modulating effect on the functionality of the hemispheres. So now all of a sudden I have this underactivity in the right-hand side of the brain that's been there. I have this overactivity in the left hemisphere, and I drive and I drive and I drive the left hemispheric function. I am going to get suppression. Now I can do that therapeutically and I can make the matter worse. But one of the things that is definitely making the matters worse, and again, I know you were a big part of this summit, the digital summit, mm-hmm. is that a lot of this digital interaction is driving the predominancy of the left hemisphere.
Yeah, which is a whole different conversation.
But I just thought I'd plug that and give you around that.
That's why we that was the digital dementia summit that a woman by the name of Dr. Krista Burns ran this past month as well.
And many of participating in it.
Yeah, lots of them were participating in that. It was a great event. We have a couple other questions that have come in. Can you please explain how stimming and repetitive movements from OCD are related to anxiety, emotion regulation in the cerebellum? Can stimming be managed by working on the cerebellum?
Absolutely, stimming can be managed by doing that, because again, the circuitry is a little bit complex, but in the sense that where one of the things that the cerebellum is doing is it's firing into a relay center called your thalamus. Your thalamus is receiving a tremendous amount of sensory input from the environment, and it has these different modules in it, and it's feeding this information to different parts of the cortex, the cerebral cortex. Now, there's a gating mechanism on this thalamus called your basal ganglia. And the basal ganglia's job is to basically allow for the thalamus to fire or to modulate it down. What happens in a lot of these developmental disorders is we don't have this appropriate yin and yang between the circuitry within the cerebellum. We have to keep it simple, we have a direct loop, we have an indirect loop, and then we have a hyperdirect loop. So we have these three primary loops. One of them is an excitatory loop, and two of them are inhibitory loops, okay? So the main job of the inhibitory loops is to govern it, to monitor that amount of input, okay? The direct pathway is more of an excitatory loop. So again, the cerebellum is firing into this thalamic relay center. The basal ganglia his job is to modulate how much of that sensory input is going to different parts of the cortex, the frontal lobe, the parietal lobe, the occipital lobe, and other limbic circuits and other parts of the brain. And so what happens is that this modulator called the basal ganglia is under control of the cerebral hemispheres, specifically frontal lobe mechanisms. You have 5 primary frontal lobe loops that are coming down, and basically, if this is my basal ganglia, my thalamus, my frontal lobe is sitting here and it's firing across with these loops and basically modulating them. Well, what happens is that there are cerebellum frontal lobe loops that help develop the human frontal cortex to provide for this inhibition system, okay? But the problem is in these disorders is that there's not enough of that cerebellum cerebral relationship. And so now we're not getting inhibition to that circuitry. And so what happens is that basal ganglia it's not having that on-off switch regulated enough. And so when we get that on switch, which would be more the direct system, we now are exciting the brain. And when we see it and we excite the brain and we excite certain parts that are more sensory based, then we're going to have more stims, the sensory aspects. If it's more cognitive based, then we're going to have more of the compulsive end of it and stuff. So again, that modulation is not there. And so it's a top-down relationship from the frontal lobe down through these what we call basically subcortical networks, okay, coming down from the cortex into the subcortical networks of the limbic system and the basal ganglia networks. But it's built upon a bottom-up system. So the bottom-up being the cerebellum vestibular brainstem mechanism. And again, I think that's for all those out there in our space, is that the take-home here today is you have to build the brain bottom-up to get top-down control. And I think that's where, the game changer for me when I first encountered this work, through Dr. Malone and others, was that approach of that we have to come bottom up, because we cannot come in just from a top-down relationship. And I know there's a lot of people out there doing top-down work, but I also know they're hitting a wall. Mm-hmm. And I know that because I've listened to them lecture and I understand what they're doing. But more than anything, I know from what my patients are telling me what they've done in the past and stuff like that, and how they approached it. And then all of a sudden we go bottom up, and we remediate those primitive reflexes. We restore better vestibular integration. We work on oculomotor function. We address the cerebellum-based relationships. Then all of a sudden, this relationship of frontal lobe and functionality comes to play, and now we get inhibition. So now we see obsessions and compulsions regulate. We see anxiety disorders go down, but it's top down. Now, the double whammy effect of that is that there is a neurometabolic cascade that's sitting there that can be influenced by a variety of different autoimmune shifts, whether it's neuroinflammatory base, it's being driven by infectious agents, being driven by, again, high levels of cortisol levels. Cortisol levels will produce interleukins, IL-6, infectious agents will produce interleukin-6, so that can wind that system up. Okay, you can have antibodies to your basal ganglia that are brought on by total food sensitivities and stuff like that. So that's where the integrative metabolic work piece that has been that's transformed my practice over the last decade is very big. So you have to account for that as well. So
yeah. I mean, I think what's so the good news is that one, there's lots that can be done about it. The challenging part for a lot of people is finding the right practitioner to work with, and that's why we refer to them to the IAFNR directory, and then obviously the I refer for lots of people to you as well. And but the takeaway is that there's lots that can be done, and when you go at it from the right approach, the results come a lot faster as well.
yeah, and I think that's the big thing, and I think and recognizing the specificity of it, and I think that's where the organization of International Association of Functional Neurology and Rehab and all the work that we've put in over the years and the education of our practitioners to really get this. And it's great now because IAFNR and the Karazian Institution has opened up our field to so more practitioners. So now we're getting, practitioners that come from more the metabolic side and nutritional side. Really go, oh, wow, this is eye-opening, and I really need to know a functional neurologist. I need to, find one, because I do think that the 1,000 of us that are practicing functional neurology probably here in the States, we probably could use more patients because we're not busy enough. We should be on a waiting list because people should be referring to us or in co-managing with us and stuff like that. And so for patients that, maybe under good care on a functional medicine level, but really need the ins and outs of a functional neurologist to do a true thorough functional neurological workup, and then from there develop a rehabilitative program. Some people respond great in a week. Some people need a lot more rehab time than that. And then when you work in the childhood development arena, that is a long, long time. Okay. And to be honest, I've been doing this for many years, and I see kids at different stages. I've had the pleasure now of having cases where kids that saw me when they were 4 or 5 in my early years of doing brain balance are now 17 and 18. So now they're coming to me at 17 and 18, and there's no doubt their parents are telling me the work that we did when they were 5 or 10 and so down was a life-changing scenario, but we need to do more. And that's the cool thing about working with this population now at 17 and up, is that now I can start looking at what are the long-term therapeutic needs of these kids, and can we change the brain at 17, 18, 19, and 20. And I'm here to tell you, absolutely we can. And we can do it, even though it may seem like, wow, they're really presenting behind developmentally that of a 3-4-year-old, but yet they're 18 or 19. Can we continue to work on them and develop more functionality? And the answer is absolutely. And I don't think there's enough people doing that work to really sit there and say, hey, what can we do for this young population that maybe didn't get to a brain balance center or didn't get the necessary neurological rehabilitation when they were younger for a variety of different reasons. What can we do now at this adolescent level? And that's what's so intriguing, in having a son that is at that age group who has watched his dad do this work and now is very fascinated by what he's done, and gotten to meet a lot of former families that he's working with their 17, 18-year-old. And so to have a 17, 18-year-old son who's learned some rehab therapy to work with other 18, 19-year-olds, it's kind of fun to do and watch that whole interaction.
Yeah. Well, and when I say that you can see results quickly, results mean different things to different people. And I think that we were talking about that earlier as well, is that depending on where your child and how they're functioning, what their challenges are at this particular point in time, seeing small shifts in really important parts of their life, in terms of their quality of life and their ability to interact with others, is a massive move forward. So I don't want anybody to take away that I was trying to say that it's an easy problem to fix. It's just that we can see incremental movement forward and improvement in function and quality of life and improvement in health. And that's, I think, really, as a parent, what we're looking for. We would all love the magic bullet, but in the end, what we're looking for is kids that are constantly being able to improve their health and their quality of life.
Yeah, and again, doing this for a long time, I think ultimately it is the incremental relationship. It's not this, magic relationship of, hey, a week of intensity or 3 months of programming and stuff like that. It's because I've played around with those scenarios and I understand them very well. And I'm not to say that they there isn't a certain population that it works for. I mean, there is a certain population that you can rehab somebody intensely for a week and make outstanding results. I'm not sold on where they are maybe 3, 4, 5 months from now, but I know you can see tangible improvements in different measurements. I've seen, worked with people that we've done 3 months or 6-month programs and stuff like that. Can you see demonstrative changes in that time? Sure you can, but the relationship again is, it's still for a certain group of populations, they need further and further therapeutic models and therapy. So again, I think that that's been one of my biggest things that I've been trying to do is try to, how do you make a cost-effective therapy model that is effective for people that they can do it for a long-term time, because they need that long-term relationships. Because there are a lot of unknowns. Anybody that thinks they have the answer to autism or ADHD, I'm sorry, I think they may be in Colorado smoking too much. Okay, but the reality of it is
they can come to Canada too.
Yeah, Canada. Well, they might be able to come to Georgia here soon and do it too. But the reality of it is that I think that there's so much more long-term aspects. Do I believe that there are a variety of different things that are happening that are very good to show that we are indeed moving the needle? Absolutely. But at the same time, for someone who looks back on his own personal work over the last 15 years and tries to analyze it and say, what could I have done better? Why do I continue to learn? Why do I continue to read research or get the latest and greatest therapeutic equipment? Is because guess what? The cases that I hit home runs on are not the ones that I'm losing sleep about. It's the ones that I didn't hit a home run on or have stumped me and I haven't gotten where I wanted to be and what I expected. I want to learn from that. I want to know like what made that particular case unique, that we didn't get the outcome we desired, and how do we get better at it? And I think for me, when you're working in the space of autism, we have to be realistic to families and let them know that autism could very well be a 5, 10-year, 15-year window of therapy in some instances. Not saying that it can't be a smaller window in certain cases, but in a variety of cases it can. And when we get into more of the moderate severe presentations and you get into the severe relationship of autism and you're looking at maybe even some genetic components there that have changed the true structural alteration of the brain, you do have to take that in context. You do have to realize that there might be a structural limit to what you can achieve on a functional level.
Yeah, absolutely. So we have a couple of questions that are coming in. Elizabeth asks, can you discuss what types of activities are therapeutic for the cerebellum? Now, we've talked a little bit about that, but maybe if you can give some more specific examples of, like, if you were to parse out one of your patients' plans, what are the types of, are there movements or activities that you have a lot of them do when you know that you have to start driving into the cerebellum? I know it's going to depend on which side, but...
Sure. Well, I mean, again, one of the things that, again, we can isolate out a unilateral activity where, just doing an arm movement, a complex arm movement or something like that, or a leg movement. But one of the things that it really drives the cerebellum, and again, and a lot of times too, you may see some bilateral symptomatology too, but you'll also see a predominantly weaker hemisphere, a weaker cerebellum, is that a lot of the postural strength, okay, the muscle tone of the spine, that's a big thing. I mean, most, especially when we're looking in the child population and in the young and adults as well. I mean, is to be able to look at their overall muscle tone of their core. Okay, so one of the things I'm doing now more than ever is doing a ton. We always did core work, but we did it in a more static way. Now I'm doing it in a more dynamic way. And what I mean by that, let's say, for example, your child or your adult can do a push-up. That's great that they can do a push-up. Now, can they do a push-up with a push-up and a jumping jack element to it, okay, where they're doing, or they're doing a push-up and, they might be holding a static push-up plank, but then can they come to their elbow plank and then can they come back up and stuff like that? That's more of a dynamic aspect. So I would definitely say one easy way to activate the cerebellum is through core strength exercising, okay? And doing it in the static way, because when you can do, and what I mean by a static way is just having someone lie on the ground, lift their pelvis off the ground and hold it, for 30 seconds or 60 seconds and stuff like that. Now, you want to make it a little bit more dynamic and you work up to it, is that, are you now having them do core work off a physio ball or a booster ball or something like that? Or are they doing a movement parameter at the same time they're trying to stabilize their core and stuff? I'm doing a lot more resistant types of training with people utilizing resistant bands and weights and stuff like that, or TRX straps and stuff like that, that again, because the cerebellum is all about complex motor activity. So, again, in the old days, we used to do a lot of static stuff, but now it's fun to do it more in a dynamic position. Okay, so that would be a great generality to look at it and say, okay, do we have good muscle tone? Because there's normatives. There's normatives on what is the amount of sit-ups that a young child should do versus an adolescent. Same thing with push-ups. There is a certain level of normatives on basically pull-ups and stuff like that, or chin-ups. So there's these things like that to where if you know your child has low muscle tone, then right off the bat you got to have this big sign going off in your head: cerebellum, 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 and start working from that. And start doing, and again, the OTs used to do with a lot of the, the different, where, again, they, crab walks, or they would do, pick up the kids' feet and make them use their arms and stuff like that, or use proprioceptive vests or stuff like that. But again, more than anything, you got to actually strengthen the muscle tone.
Yeah.
So that, go ahead.
Yeah, no, well, what I was going to say to that is I think that one of the things that we miss as parents is that we go in for that one visit a week, or sometimes one every 2 weeks to the OT, but it's the frequency. We've got to think about these like daily workouts, and so talk to me a little bit about frequency and how that impacts your patient outcomes.
Yeah, again, for someone who's did various different types of treatment modalities for years, for patients that come to my office, they're on a certain frequency, maybe 2 or 3 days a week, but they're also doing activities at home. For those that I'm working around the world on a distance level, their frequencies can be every day, 2 to 3 times a day, depending on, it's case dependent, but the relationship is that frequency matters, and in frequency intensity. And I think that again is the problem that we see now in this therapeutic workup for most instances, because again, if most people are still utilizing some form of private healthcare or government-based healthcare in whatever country they're in, their treatment ban is not based on what the provider really ultimately wants. It's based on what the insurance carrier is going to do. Okay. So that being said, being in the world of fee for service, I've never had to run into that. But more than anything, what it's allowed me to do is begin to realize that, okay, a 3-day-week model for some kids or adults is adequate. But in some instances, it's not adequate. It's not even close to being adequate. So it might be a therapeutic model. And some of the patients that have reached out to me after the summits over the last 2 years, I have several of them that are on a frequency of 5 days a week, anywhere from 30 minutes to 90 minutes per day, depending on what we have to do. So it's case dependent, but I'm here to tell you that I'm more than ever, I feel that I'm arriving where I want to be, or increasing the complexity of my therapeutic plans because of the frequency.
Mm-hmm. Yeah, makes a great big difference. So
going to a therapy center, any therapy center, for an hour or 2 hours a week, or 1 hour a week, or bi-weekly, or 3 times a week, again, in certain instances, probably not enough, at least what I've been able to see. So
I think what parents can take away from this, even if you aren't able to get to a functional neurologist right away, if you're working with an OT, often OTs will give you home plans. So will speech language pathologists. I think sometimes parents take those seriously, and sometimes we don't. And I'm not saying they're not being serious about it, but we think, oh well, I'm coming into the OT. Yeah. The reality is they're all forms of neuro rehab to some degree. And the more often we're doing those things with our kids, the more.
Yeah, I mean, at the end of the day, they are neuro rehab, and then they have to be done frequently. Listen, over the years of working in my brain balance centers, I can tell you the thousands of families that we've dealt with. Many of them were like, "Oh, you want me to do primitive reflexes at home? Yeah, all right, whatever. You want me to do eye movements at home? Yeah, all right, whatever." So that became a very frustrating aspect. And then you want to know why your child is not X, Y, Z at the end of 3 months or 6 months and stuff like that. Where now, in the context of how I'm building these programs, I mean, again, anybody that comes and sees me, at the end of the day, it's like, this is the model. I mean, this is what you're signing up for. And if you know you can't commit to that, then yes, we're probably not going to be a right fit, because it's about getting from point A to point Z, and it's going, in a lot of instances, take a while, and we have to rev it up. But I think for me, more than anything, is that the frequency allows you to then change the degree of the specialization of the therapy, and so it doesn't become a boring application. It doesn't become a thing where, like, oh, I'm doing the same therapy for 10 weeks. No, guess what? We're able to evolve your therapy plan because we did it at a high frequency and stuff. So
Yeah, and I think that the great thing about it too is what you do is you work with the parents to customize based on one, what timing, what is going on in their life, how frequent can they do it, and making sure that depending on where their child's at, that it's approachable with the child too. So that's the great thing about working with someone like you who can customize things for the maximum effectiveness within the resources that the parents have at the time, but also saying if you're not going to do it, it's not going to work. So
yeah, and the same thing working in the young adult population, working in the adult population, again, working with especially with adults that have careers and this and that. At the end of the day, I'm like, listen, if you want to get better, we got to do this, because if not, then you know what? I will ask you to come to my office 4 days a week, and you're going to be mad at me when you're paying 4 office visits rather than 2, because you could be doing the rehab at home and stuff like that. So those are the things, and that's just the practicality of building a therapeutic plan. But at the end of the day, if the one takeaway people can really look at is making sure that if they are being assigned a home-based plan by any of their providers, to actually follow through on it, because the provider's not giving them that just for the sake of giving it. It's just saying, listen, your child or your adult needs this more enhanced version of stuff. So
yeah. So one last question before we sign off for today. Amy asks, so bottom up with primitive reflex and integration. So I think what she's trying to do to clarify, do you always have to start with primitive reflex and then do the cerebellum work, or can you do them together?
yeah, you can do them together. There's no reason to sit there and say that you have to just work through, because at the end of the day, when you're doing all these primitive reflex integration exercises, I don't care who assigns them to you. At the end of the day, you are utilizing the cerebellum. There's no way you're not utilizing the cerebellum and the frontal lobe. And the reality of it is that the reflexes going away is a sign that there is better input from the cerebellum to the frontal lobe, because again, remembering what the frontal lobe does is not only fires down into those limbic basal ganglionic loops, it's firing down into and putting inhibition on the brainstem. And it's coming from the fact that if you look at all these primitive reflex exercises, what are you doing? You're moving. So if you're moving, you're activating the cerebellum, and you're driving this top-down relationship. So
Yeah. So I mean, I think that we've gone through a lot of what we talked about going through today. Is there anything else that you think people need to know about how doing this type of work will make their child life better in terms of the emotional regulation? I don't know if you have a specific example of something you can think about. I know I have one I can share in a minute, but
no, I mean, I think for me, it's more of just getting parents to recognize that the cerebellum signs are around them. They're there, and they're a child or they're adult. And if you're not addressing them, they need to be addressed, because if you are asking for better cognition, or you're asking for better behavior regulation or emotional regulation, and that's what you're asking of your therapist, and you're saying, when's that going to happen, and it's not happening, okay, then I'm here to tell you, you're not addressing one of the primary problems. And one of the primary problems would be that cerebellum. And I'm sure if we went and did a very comprehensive cerebellum assessment, we would probably find that cerebellum is not developing neurologically, or has had these breakdowns in these different networks. And once we start addressing them, then all that that other stuff will begin to take hold. Because again, I get other therapists in a variety of different disciplines were referring to me, and they're frustrated because again, they're feeling distressed. They're feeling distressed from what the expectations and what the results that the parents want for their child, and they're not getting there. And so they're doubting themselves. I'm like, listen, don't doubt yourself. It's just where you are in what you're trying to achieve here is dependent on down here. And once we get in here, yeah, guess what? We could, certain children do need cognitive behavior. They do need psychological counseling and stuff like that. Doesn't mean that a functional neurologist is going to address the underlying trauma that's sitting there that's embedded on top of the immaturity in the brain and stuff like that. Okay. Or the circumstances of the home they're growing in, or the family unit they're growing up in, and stuff like that. That is not what I'm saying. I am saying that let's address the hardwire of the neurocircuitry, and then the cognitive behavioralist therapist or the neuropsychologist can go in and alter the software of the brain.
Yeah.
So.
It's what I can say from our experience, it's actually sort of first what I was going to say is that what you're talking about too is a lot of what a lot of the people that do work on the metabolic side, on the functional medicine side, will say about things like we don't resolve how the child is feeling in their own body in terms of like they have chronic constipation and stomach pain and everything else. It's very hard to do behavioral therapy when they're feeling so crappy all the time.
Oh yeah.
And they're still uncomfortable. And it's the same thing, but you also can't work on changing how they interact with people and at that higher level if they haven't developed that lower part of the brain appropriately.
Yeah. It's like, working with these kids or working with these adults, and you develop their right hemisphere and you develop their social engagement system. Then, okay, they're going to get more benefit out of a social skills class and stuff like that. And they're going to be able to really engage in that context there. But prior to that, probably not. And so, again, to me, it's addressing this hardwire relationship through the neurological rehabilitation process, and then see that. But the take home for me is that I want parents to realize that the way they've been conditioned to look at these symptoms, we have to change that dialogue, that relationship, and realize that, again, if you are looking at social cognition, working memory, executive functions, emotional dysregulation, those are yes, the classical signs that we'll see in a variety of these diagnoses, but they have now all been connected to the cerebellum, and you need to have someone in your therapeutic plan to be able to assess the integrity of that cerebellum.
Yeah. And what I was going to say in terms of my personal example was when we initially started doing work with you at your new clinic, and we were getting to that point where we started to do even more intense work, we saw a massive jump in, both cognition and emotion, as I said at the beginning of our conversation today. But from just to explain parents, and what I mean by that is with respect to emotional regulation, just the ability to take a pause and then settle yourself back down. So those meltdowns that would have happened over something, whatever the issue may have been, that ability to see that she was struggling with overreacting, being able to recognize it, and then being able to settle herself back down much faster, much faster, or avoid it altogether. Unbelievable change. And it was unexpected for us when we first were doing this work.
And I actually have a case that now you tripped my mind. I do have a case down at an adult that reached out to me from the summit, who was dealing with a lot of limbic activity and high anxiety, high stress aspects, and again was doing a lot of great metabolic stuff, was doing awesome stuff, seeing some really phenomenal metabolic practitioners. And then she happened to hear one of the summits, and we got talking about the cerebellum, and then she reached out and said, like, listen, I really think I have a lot of cerebellum stuff going on. And we did a cerebellum assessment, and sure she did. and was just blown away that once we went in there and started doing all the cerebellum, that, okay, now I'm not triggering and losing it on my kids as fast as I once was, or my anxiety level is down, and I can actually, have higher levels of working memory and processing speed and stuff like that. So again, the cool thing about working with the adult population is, like you said, they can give me that feedback, and they can tell me what they're feeling, and so it now allows me to understand more of what might be going on in that child with a developmental disorder that may not be able to verbalize to us what's going on, and so it makes an explanation to the parents to say, okay, hey, we're going to get here. Here's how we're going to get here, and we will see the symptom presentation begin to resolve itself over time. So
yeah. Well, I mean, part of that was also the self-awareness that came out of it. So she's not a young adult. Well, I guess she's getting there.
Yeah, she's getting there.
She's getting there. She's way taller than me now. But it was also that awareness and being able to articulate how she was feeling about certain things too. So that it goes to show you. I mean, we did talk about this. These are long runways. We've done work over many years. But the improvements to quality of life are undeniable, and those improvements in terms of what they are and how big they are is really just dependent on where your child's at this particular point in time. So it's not really great to compare one to another because what may seem little to one person is massive to another. So I just encourage everybody to get out there and find someone like Dr. Scire, or go to Dr. Scire. He works with people remotely. And as always, we'll put his contact information as well as the directory for IAFNR. And if you're a practitioner listening to this too, the IAFNR conference happens in, I believe is it October this year? I think.
I think so.
It truly is an integrative practitioner conference. They welcome people from all walks of life to come and learn about what they do and share ideas in terms of how we can collaborate together. So I encourage people to go to that as well.
And I'll encourage people to, obviously, if you didn't get to catch it on the first run, watch what we're doing, because we'll make sure we'll post some pictures from the articles that we reviewed today, and try to have this more comprehensive conversation, because again, this could be a very 15-hour, 20-hour lecture on the complexity of neurology, the cerebellum, and all the loops, and again, I want to bring awareness to these researchers, because I don't think that these researchers are I think they're getting seen at some of these academic conferences in the neurology world, but it's not hitting even the world of developmental arena, because a lot of these guys are not getting invited to these conferences and being able to speak. And that's why we hold IAFNR. We try to bring some of these big time researchers that are publishing papers, 5-10 papers a year, and no one's reading unless you're a geek and really getting excited. Because anytime I have my PubMed filters set up to where I get alerts, and I'm like, oh great, this is great, brand new paper I can read. So, but that's a big thing, is it trying to take what is, to me, mainstream science, mainstream, Schmann's at Massachusetts General. You're not getting someone with a higher credential. I mean, he was the former president of National Ataxia Foundation and stuff like that. Okay, I think he actually still is the current. So you get a heavyweight like this saying this is what, and now that he's been doing this for 30 years, and they have a consensus. I've had papers that this is a consensus on the cerebellum, the 20 leading authorities in the world on the cerebellum. This is how the cerebellum is being written. So a textbook on the cerebellum in neurology is different today in 2019 than it was in 2000 when I was in the middle of my in the beginning of my postdoc work and stuff like that. So we have, and I think that's what I love about functional neurology as an overall discipline, is that a large segment of us are not only practitioners, but we're out there trying to read the literature and trying to adapt the literature to a therapeutic entity very quickly, and then get to conferences and lecture about it, to sit there and say, hey, this has got to be mainstream thought. This has got to be standard of care or best practices and stuff. So
no, it's fun, because I like this stuff. It is really fun to watch, because it is and to watch all these all of you functional neurologists working together to continue to elevate the profession on an ongoing basis. Yeah, for those of you that don't see the behind the scenes of what goes on in these organizations, the degree to which the sharing of information and teaching each other what they've learned and the up-leveling of education is actually, you want to talk about people with lots of initials after their names. I started to stop saying them all, wasn't like introducing them because we could go on forever. So there is a lot of science behind all of this. I think that's what we're trying to get at here. And it does take a long time for that to get into mainstream. And we're working on it collectively together. And I'm hoping more and more parents that start to apply this will talk about it as well, so that more people will be listening, because it really does make a massive difference. So,
well, you've created a great platform for this to happen, to have not only me and my other colleagues and others to be able to take this, that are in the trenches with the families and with other patients, and trying to apply this knowledge base, whether it's on the metabolic side or the neurology side of it, to be able to get this out there as quickly as possible and try to close that gap between, what is research and what is clinical application that most people on a good day estimate is a 10-year gap. Mm-hmm. We try not. I mean, anytime I'm reading a paper or looking at something, okay, how can I immediately apply that to my current therapeutic model to improve my therapeutic model and stuff. So, yeah. All right, on that note, I have to run. I do have patients.
Go see a patient. Thanks again for your time again, and I look forward to doing this again soon.
All right, sounds good.
Thanks.
Thank you.
Bye for now. And thanks to all of you too for watching today.